Hello and good evening. Welcome everyone to this evening's myth busting webinar. I'm Chiara de Biase, Director of Support and Influencing at Prostate Cancer UK. I work in the part of the organisation where we oversee the activity of our direct services to men and their families, like our health information and our peer support, as well as all of our important work alongside our NHS clinical community, such as our Clinical Champions programme and our policy and health influencing team. I can already see we've got lots of people starting to watch, which is great. Everybody's welcome. And before we properly begin, let's just take a moment for a little bit of housekeeping. As you may have heard, this webinar is being recorded, but just for your reassurance, attendees, all of you out there, we can't see you and we can't hear you, so don't worry too much about that. As we move through the evening, please start to think of some good questions that you'd like to ask our panel when we come to the Q&A section, and then pop those questions into the Q&A section of the chat on your Zoom screen, and the team will be picking these up in the background. I'm sure there'll be the odd question that even our esteemed panel can't answer. And if that's the case, we will do our best to take those away and get an answer to you and shared back to you as quickly as possible. So just to set the scene a little bit before we get started properly. A huge part of the work of my team is about sharing information with men and their families so they can make informed choices about their prostate cancer risk and what treatment options are available to them. Knowledge saves lives, and we know that it's our job to get the right information to men at the right time so they can make the right choice for them. Prostate cancer in some ways is quite unique, which makes it tricky to explain, to describe, and to raise awareness for. Where the prostate is and what it does is a mystery to many people, even though over 50,000 men are diagnosed with prostate cancer every year. NHS England does a great job of raising awareness of cancer, but most of these campaigns are alerting people, quite understandably, to the signs and symptoms of cancer and to not ignore them if you notice them. But we're here tonight talking about a cancer that, in its most early curable stage, doesn't start with signs and symptoms usually associated with a cancer. In fact, it doesn't normally give a man any warning at all, which is why the risk awareness message we all work so hard to promote is crucial to saving more lives. 12,000 men still die from their prostate cancer every year. It doesn't need to be like that. It's a number that we talk about a lot at work. It's a number that drives all of us to work hard, to do what we can do to bring that number down as quickly as possible by working together with people like you, our supporters, with our ambassadors, our partners, with our amazing community-led organisations, so every man knows his risk of prostate cancer. Prostate cancer is synonymous with innuendo and embarrassment, but these myths and misinformation act as barriers to men seeking support in a timely way. Nobody likes to think about cancer. It's a subject that many of us find uncomfortable to discuss, but not talking about it doesn't take away from the fact that half of us here tonight will hear the words, "You have cancer." But wouldn't it be great if, because of the work we're trying to do here together, those words are quickly followed by, "But we've caught it early and there's a cure." So that's what tonight is all about. Empowering you to go into your communities, back to your families and your friends, and start having conversations, sharing information, tools and stories that can help men separate fact from fiction and give them the power to navigate prostate cancer. So at this point, I was going to hand over to my co-host for the evening, and I'm just going to have a quick check to make sure there's nothing in my notes. But unfortunately, for some reason, Marvyn hasn't been able to join us this evening. So our co-host was going to be Marvyn, who knows a thing or two about empowering men to look after themselves and building communities. Marvyn is the host of an incredible podcast called Dope Black Dads, which is a big part of our myth-busting campaign, helping us to work more closely with Black men this Men's Health Week. Marvyn was going to tell us a little bit more about his work, about his involvement in the myth-busting campaign. I believe we have developed a podcast actually with Colin McFarlane, which has been hosted by Dope Black Dad. So please take a look on our website because I think that's where it's been hosted. Perhaps if my team that are listening, you could maybe drop that into the chat, the link to that podcast, then people could take a look at that afterwards. He was going to talk a little bit about some of the unique challenges that Black men face looking after their health, but we've got some great speakers tonight who will hopefully be able to fill in some of those gaps for us as we go through the evening. One of the other really important messages he was going to touch upon was how important building trust in the Black community is. And without Marvyn being here, all I can reassure people this evening is that as an organisation, we are entirely committed to advancing racial equity when it comes to the access for the Black community into healthcare. And we can only do that through really meaningful partnerships, such as the one that we've developed with Dope Black Dads. So to get us started, we'd like to see if all of you here this evening can separate fact from fiction, part of our myth-busting campaign. We're going to ask you 3 really simple questions using a Zoom poll, which should appear on your screen shortly. So please go ahead and click your chosen answer for each one. So we've got myth 1. Research shows that lifestyle choices like diet, exercise, and stress are the biggest risk factors for prostate cancer. Go ahead and pick true or false. Now, because I'm hosting, I can't vote, I don't think. So I'm going to just assume that we're going to come up with the second myth. There we go, like magic. So the second myth, the first test for prostate cancer is the good old finger up the bum. True or false? And finally, let's move to myth 3. Myth 3, all men are at the same risk of getting prostate cancer. True or false? Okay, thanks very much. Let's take the polls down. So as I've said, this is all very much part of our myth-busting campaign that we kicked off last week. We went out onto the streets of Manchester and asked the public some intriguing questions such as, what on earth is a prostate? And we had a little bit of fun with it. So let's take a look at what happened.
Yes, lots and lots of big baboons. Welcome to Britain's Biggest Questions. I'm your host, Colin McFarlane. Men's health, it can be a minefield. With the sheer number of myths and misinformation flying around, every one of us has gaps in our knowledge. Yes, even me. Well, it's time to change that. So we've sent our reporter to the streets of Manchester to clear a few things up. Nikki, it's over to you. Nikki.
What on earth is a prostate?
Your
Did I hear that right?
Up your back passage somewhere.
It's a gland, isn't it?
Helps reduce semen.
Absolutely right. It's about the size of a walnut.
Wasn't there strips than that? Wow.
Do you know which groups of men are most at risk of prostate cancer?
I honestly don't know. Men.
Yeah, correct.
Old people. 25 to 50. People with unhealthy lifestyles, maybe.
Men over 50 and men with a family history of prostate.
And black men.
Interesting.
When should you speak to your GP about prostate cancer?
Great question.
Not sure.
It's when you find yourself having to get up a number of times in the night to go for a wee.
Don't wait for symptoms, because you don't always have symptoms.
I didn't know that.
And what's the first step to being tested for prostate cancer?
Who, what? Sorry?
No idea.
You might have to go through my, my behind.
I don't know. I'm so sorry.
It is to go for a blood test.
Is it?
It's a simple blood test.
Right. Fantastic.
Oh, I did not know that.
Do you think your GP would invite you in for a test if they thought you were at risk?
I bloody hope so, but
It's not mandatory, but they do pull you up when you get to a certain age.
test.
You can ask for one. There's actually no screening programme in this country.
Oh, wow.
I'll speak to the other half about it when I get home, and I'll probably give the doctor a call.
And there we have it. Let's keep busting those myths and prostating the facts. See what I did there? Prostating facts. Because catching prostate cancer early saves lives. Separate the facts from the fiction today with Prostate Cancer UK's Risk Checker. It could save your life. Thanks for watching.
I hope you all enjoyed that. He's got a fabulous voice. He really should work in TV. So let's take a look at our polls that you've done. Very interesting results. So myth one that we asked you was research shows that lifestyle choices like diet, exercise and stress are the biggest risk factors for prostate cancer. 32% said that was true, that they are the biggest risks, and 68% said false. Really, really interesting. So I don't know how we're meant to be doing this, but I'm just going to tell you my thoughts on this. Ordinarily, with cancers, we always advise things like healthy lifestyle choices, diet, exercise, reducing stress, etc. But with prostate cancer, as much as it's really healthy lifestyle choices is really, really good, with prostate cancer, it all comes down to risk factors. So prostate cancer is a cancer that increases with age, so men over 50, but it's all about risk for Black men over 45 and for men with a history of prostate cancer in their families. Let's go to myth 2. The first test for prostate cancer is a finger up the bum, the digital rectal examination. Well done, folks. So 16% still said true, understandably, but the vast majority, 84%, said false. Of course, we now know that actually the very first step on that prostate cancer pathway is to have a PSA blood test. If a GP does need to do a rectal examination, there's normally a really good reason why they want to do that. They could be looking for other problems with a man's prostate. And if that does happen, it's over pretty quickly with a bit of discomfort, but all in all, well done. 84% said false. And then the last one. Myth 3, all men at the same risk of getting prostate cancer. 20% said true. Interesting. And 80% have said false. So we've said that in terms of risk, we've gone through those risk categories, but we know that Black men have double the risk, so are at a higher risk of getting prostate cancer than other men, as well as men with a family history of prostate cancer, who have 2.5 times the risk of getting prostate cancer. Well done, everybody. Thanks for taking part in the polls. Let's get back to the action. So alongside our quiz that we did on the streets, we also ran a nationwide survey. There are lots of statistics coming your way now, so I hope you find some of them interesting. And if you lose track of some of them, we can always follow up. So because we know sometimes it takes a while for our statistics to land and understand them, but we thought they were interesting enough to share this evening. We found that 74% of men could not correctly identify what their prostate does, and 44% don't know where it is. Almost 80% of men underestimate how many men die from prostate cancer, which, as we've already touched upon, 12,000 men die from their prostate cancer every year. It forms part of this myth that we've been talking about this week, that a lot of people assume that most men die with their prostate cancer rather than from their prostate cancer. And those 12,000 men, we know that unfortunately is not the case. Just over half of men, 53%, think they'll be invited for a test if they're at higher risk. But the truth is they won't. As we know, we don't yet have a screening programme in the UK for prostate cancer. All men over the 50 are eligible for a free PSA blood test. But quite understandably, with 52,000 men diagnosed every year, there's a huge proportion of people out there that would be waiting for a test, which is why this information is so important, so that men can advocate for their own health when they go and have that conversation with a GP. And finally, last statistic, 59% of men don't want to bother their GP unless they're in pain or have symptoms. But again, as we know, early prostate cancer often doesn't start with symptoms. So 60% of men are waiting for something to happen before they speak to their GP about prostate cancer. All completely understandable, but all reasons that sit squarely with us as a prostate cancer community to share that risk message so more men get the help that they need in a really timely way. I hope you found that fun to listen to and hear about the public perception of prostate cancer and what it means to us in terms of where we place our efforts in dealing with some of these myths and misinformation. So now we have the pleasure of meeting some men with prostate cancer who very kindly agreed to share their personal experiences of the myths and misinformation they've encountered to help everyone understand a bit more about how we can address them together. I'm also joined by one of our expert specialist nurses, Sophie Smith, who can help put some of these experiences into the wider context of thousands of men with prostate cancer that she has supported during her time at Prostate Cancer UK as a senior specialist nurse. I'm just going to hand quickly over to Sophie, who's going to introduce herself.
Hi, yes, I'm Sophie. I'm one of the specialist nurses here at Prostate Cancer UK. I started my career as a urology nurse for 9 years, and then I moved on to become a prostate cancer specialist nurse for 5 years in the NHS before coming here to Prostate Cancer UK. I'm now one of the senior specialist nurses here at Prostate Cancer UK. I've led clinics in the NHS, specifically looking at managing side effects post-treatment, and also on service development, which is also what I do here at the charity. I specialise in helping men to manage their side effects, and especially erectile dysfunction. And I've also helped to set up the sexual support service here at Prostate Cancer UK. I think we're now going to hand back to Chiara and start with talking about the myths about prostate cancer.
Yeah, thank you very much and welcome. Thank you so much for joining us this evening, Sophie. So our first myth revolves around lifestyle. Many people believe that leading a healthy lifestyle, eating the right foods, or even having lots of sex can prevent prostate cancer. However, we'll uncover the truth that modifying these factors unfortunately cannot eliminate the risk. Here to share his personal experience is Stephen Shaw. Over to you, Stephen.
Hi, I'm Stephen Shaw. I was diagnosed in 2019 with stage 3 prostate cancer. Up until the age of 60 hours, 40 hours, a well, healthy man. I had no real issues. Body-wise, I always looked after myself. I played semi-pro football for many years. I got around to 60, I went to my local doctor to discuss a few problems I had in my back. And as I was getting up to leave, we discussed what we were going to do, go to a physiotherapist. She happened to say to me, is there anything else that's been bothering you, Stephen? And I happened to mention the fact that I'd had a couple of sessions of erectile dysfunction. And at the time, you know, the question was this when you've been out socially for a drink? Or, and I says, no, it wasn't attached to that at all. So I was invited back to the doctor's surgery to have my bloods done. And within 5 days, my blood test come back with a PSA of 13.4. From that stage, then I was actually then went to the City Hospital at Nottingham within 2 weeks to start the procedures of scans and biopsies. And at that time, you are open for the best. Well, I was certainly thinking that I was infallible, that I've always been a fit guy, that this could just be a knock on, you know, something we need to get to grip with. But unfortunately, the first oncologist guy I seen, he explained what was the symptoms, what it was. I mean, the diagnosis was. It actually, then he mentioned the word that it could have thought it could be a case of palliative care, which by then my world, and I sat with my wife, my world just sort of like dropped from underneath me. I didn't quite take it all in. Emotionally, it drained me. I was invited to go into another part of the hospital, to the room. I was given, well, prescribed hormone tablets to start taking straight away. Then on the Friday, I got a telephone call. It wasn't, I always remember the Friday. My specialist nurse rang to say not to start taking the tablets. The fact that they'd had a meeting on the Friday at the urology centre, and my paperwork came across another oncologist who wanted to chat to me and discuss different things, but not start taking any medication yet. So the following Wednesday, I went to see my oncologist, who I call God. Sorry for that, but I do. He explained it in more, and in the meeting there was people from, there's 6 people in the room, quite honestly. My wife, it was very intimidating. But these people were from the research development in City Hospital Nottingham. They wanted to talk to me about going on to the Stampede trial. The oncologist explained to me that I got no chance of having my prostate taken away because it had leaked into my lymph nodes at the back. And also there's a small shadow at the front. From there, he told me that we'd be looking at 6 sessions of chemotherapy, followed by 37 sessions of radiotherapy, and then 3 years of hormone treatment. But the hormone treatment was not going to be tablets. It was done by patches, which the research people there, which I'm still under the research people, who I entered the trial at Stampede trial. And so 4 years down the line, I've just moved on to now 6 monthly blood checks. I go in July. It's the longest I've gone without going back to the hospital from 3 months. It's I would say the week coming up to it, I'll be very frightened again. It's been very frightening time. And as Sophie, you said earlier, Sophie, I just said about all the side effects. You name them, Sophie, I've had every one of them. And it's been a very tough time. Seriously, I'm from a man that's been physically fit, always been in control of myself. I was a production manager for many years. 162 people report to me, plus overseas as well. And I came into a crumble. Diagnosed with cancer and not catching it early. I didn't catch it early because I didn't have no symptoms. But being diagnosed stage 3, it's left me a different person altogether. A very, very different man altogether. From being the confident guy I was to, it's gradually coming back. I'm not saying it isn't. It's gradually coming back. The Stephen Shaw I know is gradually getting back to where he should be. But it has been long, and I will say the hormone treatment is a killer. It really is. It drains you when you actually, the fatigue. And I find that very odd because my testosterone level was very low for a couple of years, 0.01, and I couldn't understand why I couldn't even play golf. I couldn't even get onto the golf course again. I got my own little business. I was going to work in the morning. I had this attitude where I will keep going and going and going. And my oncologist said to me sometimes, you're going past where your body needs to be taking you. But I kept going and going and going. And I came home and I was taking baby naps, and I found it so embarrassing. I found it so embarrassing. And I'll tell anybody out there the embarrassment of my grown-up children coming and finding their father, fit father, on the bed at dinner time, asleep. I was so embarrassed. So embarrassed. I've had, yeah, it really was. It took some getting used to, but slowly but surely, I'm turning that corner and starting to be more active. Well, a lot more active. But it's, you know, I will say it's not been easy, and the side effects, the cancer side effects, I couldn't get the 6th chemo because I was having Detoxetone. I couldn't have the 6th one because I got no feelings in my fingers and my toes. So my oncologist cut the last one. I wasn't going to tell him because I wanted but my wife made me tell him the fact, because every time you go, every 3 weeks after it asks you how you're going, and I was going to keep it because I wanted this, because you want this magic potion to work. And if I'd have gone on my own, I would never have told Dr. Chadwick. I would have, but Anne made me, you've got to tell him, because, you know, he's already explained to you. You need to understand, but yes. And the radiotherapy, for as long as you're there, it's very time consuming. It's very, very hard to go 37 sessions of radiotherapy. It's very, very hard. It's tough. It's tough. Okay.
Thank you very much, Steve, for sharing that so beautifully and thoughtfully. I don't think there'll be anybody that's listening that doesn't really feel the impact that this treatment has had on you, as you know, particularly around the ADT and the hormone treatment. And I don't think anybody that hasn't gone through it will quite understand that feeling that you have. It really comes across really clearly about that embarrassment that you felt, and taking your baby naps, and I realise it doesn't make any difference when the rest of us sit here with full understanding of why that would be happening, but for you that felt a real core challenge. I can feel that from you, so I really appreciate you sharing that. Just out of interest, when you've shared your story or talked to people about prostate cancer, Steve, have you come across any of these myths when you've been talking to your friends about it?
Yes, I have. You know, a lot of people, and the thing, people, you know, men around my age, and you know, people I know socially from golf and family, and I've told, you know, spoke to family people, they're looking for side effects. We're not looking for symptoms, and they're not there. You know, you don't have to wait. You know, and one of the things I always say, and they say to me, I'll say to them, if you're in the doctor, just ask, you know, whether you're, you know, to go for if you can have a PSA test. And I think some people, you know, I can see it from my footballing background when I go and watch local football, and people see me around my age and we talk and that. I think the thing is that, well, it's not going to happen to me. I do pick it up. I really do pick it up, because when you've spoke about it, they ask you how you are, and you said the one thing which changed, this really did change my mind. When I first got asked about it, I never told anybody properly to start off with that it was through talking about erectile dysfunction, because I was slightly embarrassed. And then I just said to my wife one day, and I said, you know what, I know somebody has to be again. I'm going to tell them the real truth. Why? Because otherwise, this is not going to work. I'm not going to, you know, people say to me, well, how did you find it? You can't sit there. And when I told my sons, you know, I was taken back. You know, I've got to tell my 38-year-old son and my 36-year-old son, this is why I found it. Because, you know, the first thing they kept saying, well, how did you find it, Dad? How did you know? So, you know, I decided to say it. And even when we out socially now, somebody says to me, well, how did you find it? I have no qualms or no problems saying to somebody, it was through by just saying to my doctor, I'd had a couple of cases of erectile dysfunction.
That's really brave of you, because I think, you know, this is what we're here for. That is absolutely the heart of what it is, that embarrassment around the way that we talk about sexual function, or anything that men have these associations, and not just men, everybody, all of us, men, women. This is one of the most common, well, it's the most commonly diagnosed cancer in men, one of the big 4 cancers, yet we still can't find the words to talk about it. And I guess I am incredibly grateful for what you're doing to help us spread the word by just telling your story and being really honest about how you found it, and talking to your sons. And yeah, it's really, really important. And Sophie, I wondered if this is something that, you know, is Is this something you come across all the time? Is this a very, very regular story that you're hearing? How does it feel from your perspective?
Yeah, I mean, absolutely, Steve. Thank you so much for sharing your story. And I think that it resonates so much with what we hear, and also it will land and it will resonate with, I'm sure, a lot of our supporters and our service users as well, because it is embarrassing to talk about. But also, I know, Steve, you were saying kind of that you were a fit man, that there was nothing wrong with you. And that's what we hear so much, men, and I know you were saying, you kind of caught it later. And that, again, is what we hear so much, because, men will say, well, I've got no symptoms, or I've got, I don't need to because I'm fit, I'm healthy, there's nothing wrong with me. Or I've never smoked, I've never drunk, I've never, I've played sport all my life. I'm not going to be at risk of prostate cancer. Where in fact, unfortunately, that those aren't the risks. You're not going to reduce your risk of getting prostate cancer by leading a healthy lifestyle. Now, of course, we know that leading a healthy lifestyle is going to better your well-being. It's a good thing to do, and it is going to decrease your risk of potentially other cancers. And obviously heart disease and lots of other things that are going to potentially lower your life expectancy. But for prostate cancer, that's not the case. It does, if you get prostate cancer, it does, if you're of a healthy weight range, it actually does decrease your risk of having advanced prostate, more aggressive prostate cancer, and recurrence of prostate cancer. So actually leading a healthy lifestyle and being of a healthy weight is really important, but it's not a risk factor. It's not going to reduce your risk factors, because those risk factors, as Chiara said right at the beginning, are being of a Black ethnicity, are being of a certain age, over 50, and also having a family history. So those are the risk factors. Being healthy are not, and symptoms also are not. We know that men who have symptoms, are often, it is too late. It is starting to become a disease then that is later. So, that's where these raising awareness of men, so that they know that you have to be aware of this disease at an earlier stage.
Thank you. Yeah.
It's really important.
Thank you, Sophie. And thank you very much, Steve. Thanks for sharing your story. And I'm sure there'll be some questions coming in for you. I'll try and have a look in the next section. So thanks for that. I'm going to move us on to our next myth. Myth 2, the digital rectal examination. We often hear misconceptions about the digital rectal examination, or the DRE. And as I've already said, there's often a really good reason if GPs still do it, but we know that not all of them do. In fact, we think that less than half of them will do that now. Many people think that all men will need this procedure, but that's not true. So we're going to spend a little bit of time now with our next speaker exploring the reality of DRE. So this evening we have joining us our next guest, Mr. Patrick Williams. Patrick is also sharing his incredible story as part of our Men's Health Week campaign. He's done so much for us as a volunteer at Prostate Cancer UK, helping us raise awareness, especially amongst Black men and their loved ones. Patrick, I'm going to hand over to you to briefly introduce yourself and talk us through this second myth.
Okay, well, my name is Patrick Williams, and I'm 67 this year. I know I don't look it, but it's cleverly disguised by this camera today. What can I say about me? Originally, as a profession, I was a dancer, so I was pretty fit, very much in control of what I did. I was someone who went about life without even thinking about what was going on. I certainly didn't think that I had any symptoms, so I just carried on. But I then joined prostate cancer as a volunteer in 2017, and I felt quite challenged, because I kept talking about going and get tested for a PSA, but I never did. So I felt that I had to go and get one then. And I went to have one in October 2019. I didn't hear anything back for ages. So when I went back for my follow-up, I was then told what my PSA was, which was incredibly high. Now, because of this, I was fast-tracked onto a variety of different things. One being the prostate MRI, the bone scan was the next, and all of this information the urologist then had when I went to see her in the hospital. When I was there, she decided that it was important that she confirmed the diagnosis by doing a DRE. Now, to tell you the truth, this is one area that I thought, no, no, no. I am a black man. We do not have anything up our backsides. And to think that someone is going in there to root around and digging for gold is something that was not part of what I wanted at all. So I was so tense about this whole experience that, to be honest, I I didn't feel a thing. I was more concerned about what she was going to find than what was happening to me. And I kept looking at her face. And after she had done it, I just ventured to say, "Is everything all right?" And she said to me, "No." Of course, I was quite shocked because I was not what I was expected to hear. And then she said to me that I was expecting to feel something soft, but it wasn't. It was hard and lumpy. And then she went out the room and quickly was followed back in by another woman who was wearing a badge of which I read Macmillan on. And I didn't have to have rocket science education to realize what they were going to tell me. But I did ask quite a lot of questions about this idea of doing the DRE. Was it necessary, having had all that amount of information you had? Because you had the PSA, 2 PSA results. One was one level, and the other one had risen. The MRI, and you had, it's important that we needed to affirm every single thing. We cannot miss anything where this was concerned. Your MRI results were bad. They were dire. The bone scan showed that there were things happening in your bones, right? Your ribs, the femur, the tibia, right? And we just needed to do this. It was another stage of confirmation. And I thought, okay. So when I got the biopsy, which was, to be honest, I'm going to tell you this for what it's worth, I would do the finger up the bum any day than to do that wretched biopsy. I think it's the most disgusting, horrible experience that I ever lived through, right? And to be honest, the finger up the bum was only less, well, between 5 and 10 seconds. So to me, what is the difference? That didn't make me gay, because that's a myth that I've heard all about as well. Oh, you're going to become gay if you put the finger up the bum. That is like the biggest nonsense that I've ever heard, right? And I can virtually vouch for that, and that isn't true. And it's going to be painful, but I suppose that some people would feel that it was painful, but to me, that wasn't painful at all, because I was more concerned about what she was going to find and what was happening to me. So my focus was different. And when my diagnosis came back, it was a diagnosis that I wasn't prepared. And just for everybody out there, right, Sophie was the specialist nurse that I spoke to on the helpline, who gave me all the support that was necessary when I laid it all out to her. So there you go. I've come full circle tonight, I suppose, can say. Yeah, so that's me.
Thank you. Thank you very much, Patrick, for making that so relatable and light, as you always do. Thank you very much for sharing that. I'm just going to ask a really quick question about, is there anything else from the Black community? You said there about the perception of having a DRE is going to make you gay or whatever. Is there anything else that you think the listeners and the viewers would find interesting in terms of other misconceptions, specifically from the Black community, that you think that we could tackle?
Yes, I have heard loads, right? have some soursop. It will cure the cancer. That is
What?
no
Just
clinical evidence.
explain that for us. What's
Right,
that now?
soursop is a fruit, right?
Right.
That's from the Caribbean, but of course you can get it here. It's very tasty, and you make a thing called soursop punch. And it's believed, I don't know where this has come from, that it has cancer blocking properties. So if you drink soursop punch or you eat some soursop, it's going to solve the problem, right? Well, let me tell you something. I followed that. I eat so much soursop that I don't even want to taste the wretched thing. It did not help me, right? So let's get that one out.
We'll get
The
that
other
one
one
out.
is
We'll get that
a
one
little
out.
bit of lemon juice with black pepper. You know how disgusting that tastes?
I can imagine. I
And
can
that is
imagine.
supposed to help your cancer. Again, no clinical evidence. You know, there's so many bits of nonsense that you hear. You know, and I'm telling you,
we laugh about them though, Patrick. But the fact is, these are the very real challenges, right? These are the challenges that we're facing, and that we're trying to work with the community, in the Black community, so that we can work with them to start to get rid of some of this misinformation. Sophie, is there anything particularly there about what Patrick said? Maybe just a comment about if there's anything like that that often crops up.
Yeah, it does. I mean, it's not. I mean, obviously, the Black community and the DRE is a big issue, like Patrick was saying. But it's also, you know, it can also be another thing for men who potentially have been abused, and you know, a real issue. And we've certainly spoken to men like it. So just to say, really, that if it is something that you really cannot have done, then you are in every right to refuse to have it done. It is something that can be helpful in certain circumstances, but I think now that we're having other testing being done with it's certainly not a first line test. You really don't need to, you know, PSA is a first line test. So if you're concerned about it being the first thing to have done, it's not. The PSA blood test is. And then, you know, you can then go and most commonly it is then straight to have an MRI. And yeah, then really, if it is something that you really cannot, you know, certainly for men who have been abused, or like Patrick with that sort of messaging and feelings, if you really cannot have it done, you've got every right to say
yeah,
no.
Absolutely. Thank you for reassuring people of that. I completely agree. There are often very different reasons why men would choose to not have that. I hear that loud and clear. Patrick, thank you so much. Thank you for sharing your story and telling us your version of the truth when it comes to the rectal examination. And of course, we know that the DRE still has an important role sometimes, but it's crucial for us to clarify when it's necessary and when it's not. I'm delighted actually now that we can hand over to my co-host who has now joined us. Marvyn, I don't know if you're there.
Very much here.
Hi, lovely to
Very
see
much.
you. Thank you so
You
much
too.
for joining us. I did some filling in for you at the beginning, and I'm gonna hand straight over to you to dive straight in to pick us up with that third myth. But please take a moment to introduce yourself to the viewers this
Absolutely.
evening.
Hi, everybody. Thanks for joining us on this very warm evening. There's a perspiration that's littering my forehead at the moment, which I can't avoid. But thank you so much for being here. My name is Marvyn Harrison. I'm the founder of the parenting group Dope Black Dads. It is a community group designed to support Black fathers with their experiences while they're here in the UK, the US, and South Africa also. A large part of our work is about supporting men with healthy ideas around being men and fathers, but then also introducing them into new ideas and new ways to solve some of the biggest problems in our community. So I'm really excited and honored to partner with Prostate Cancer to really debust the myth some of these really important areas. And we know within our community, we over-index in terms of diagnosis, but also not enough people coming forward and understanding. So thank you so much, Patrick, for your story also. Our next myth revolves around age and risk factors, so incredibly important. Many falsely believe that prostate cancer only affects older men, and that all men face the exact same risk. And I think that's a really important thing that we need to look into. We'll explore the truth and address the common misunderstandings around testing at a younger age. Joining us is the wonderful Luke Williams, who is going to bust the myth that prostate cancer is an old man's disease. How are you doing, Luke?
I'm very well. Thank you for having me on the program.
I'm so glad that you're here. I think this is one of the areas that even for me, I'm going to say that honestly, I still genuinely believe that I'm 28 because those were my highlight years. So the idea of doing anything mature and grown still slightly eludes me. What are the things that you feel are most difficult for Black men to talk about? And why do you think that is?
I think illness in general is a deterrent for Black people, Black men in particular, to talk. And I think it's because of the stereotypes in our culture of, well, it's a global stereotype, but I think the Black culture takes it to another level. The stereotype that to be a man, you must be strong and invincible. And I think that they find it difficult, therefore, to talk about being ill. I also think that anything that concerns below the belt is considered taboo in the Black culture. And especially for a man, he feels less of a man if he's going to say everything is not working right below the belt. And therefore, he doesn't want to share that story because he finds that embarrassing. And thirdly, emotions, that men find that they must be steely and unbreakable. And many Black men find it difficult to show those emotions. And where I'm from in Jamaica, you shouldn't cry. You shouldn't hug your dad. Well, I think it's changing now, but that's what it was like when I was growing up as a child. And I think we're gradually eroding those barriers, but there's still some way to go.
And is there a part of you that's like, you feel like you've overcome those perceptions, or like what makes you different in terms of how you've approached it? What are you braver than other people, or are you just better educated?
I think it's my mom. My mom always explained to me what a real man is, and that manhood has nothing to do with your muscles or your physical being, but more about your mindset, so to speak. And I think growing up with that teaching helped me to see things differently.
And in your view, how do you think we can best connect with younger Black men in their 40s?
I have a few ideas. Firstly, I think get Black celebrities from all sectors to promote awareness. Black people that they can identify with, people that they look up to get involved and to start talking and to say, listen, we take this seriously, you should do. Maybe working synergy with gyms and professional football clubs. This is where you'll find men in their 40s trying to keep fit, celebrating the football team that they support. Maybe have a presence at festivals like the Notting Hill Carnival. And what else could there be? Maybe have young prostate cancer ambassadors or younger. So they're not just seeing people my age, but they're seeing men in their 40s, men in their 30s who are out there talking, someone who is maybe not a celebrity, just an ordinary guy that they can relate to. And we already have memorabilia like the badge and the prostate cancer t-shirts. But do we have a slogan? I'm not so sure we do. I asked myself that today. Is there a prostate cancer slogan, a hashtag that initiates action? Is there a month for prostate cancer? I know we have March for Men, but then there's the June walk. So I'm not too sure whether we have those symbols in place. So maybe if we had those as well, that could lift awareness.
And are there any other barriers that exist for Black men trying to look after their health?
The number one thing I think is ignorance, lack of knowledge. Earlier in the Vox Pop, there were quite a few people who were saying that they didn't know what the prostate is. So I think that's the first thing that we need to educate and make them aware. Also fear that my brother, for example, when I asked him to go and get checked, he said he'd rather not know, regardless of what he's seen happen to myself, to my dad, to my uncle, my cousins, and he remains adamant that he will not go to get tested. Fear and maybe procrastination.
So, Sophie, as a specialist nurse at Prostate Cancer UK, is there any other views that you think will be important for us to consider and be aware of?
I suppose it is knowing risk, but then it's difficult because, like Luke said, you can know your risk, but you might not want to know about your risk. That makes sense. You know you're at risk. You've got a family history, as well as knowing that you're at risk of prostate cancer, but hey, I don't want to know whether or not I actually have prostate cancer or not. I don't want to go for that PSA test. So, as much information as some men get, they still might not want to go for that test. So I think, awareness is key, isn't it? And that's all we can do. I think the more, I've seen such a change in the time that I've been a specialist nurse, and the more we plug away at raising awareness, the more the more it does grow. And I hope that the work that we're doing with people like yourself, Marvyn, will just help us to become a charity that is able to get more recognised within the Black community. Because as you can see, I'm a white female. I'm not going to get prostate cancer. However, age, and yes, it's a risk factor. Because we've got men in their early 50s who are white, who still feel, like you said, Marvyn, as you age, you still feel the same age as what you did when you were 20. Men even at 50 are not going to, often don't think that they're going to be at risk until they're 60 or 70. It's an old man's disease. It's not, and so it's breaking down those myths and preconceptions, really, to be able to change that.
Sophie, thank you so much for that. That was amazing. And Luke, thank you so much also for your contribution as well. We're going to head back to our host for the Q&A.
Thank you very much indeed. That was great. Marvyn, Luke, Sophie, Patrick and Stephen, thank you. I thoroughly enjoyed that. Before we get into our final section, as Marvyn's just said, it's going to be our Q&A. If you'd like to know a bit more about our work at Prostate Cancer UK, then you can sign up to our emails. We don't bombard you, don't worry, you can cancel them at any time. But if you'd like to hear a little bit more regularly about what's happening at Prostate Cancer UK, then I think we're going to just about to drop a link into the chat. Please click that and join our mailing list. And make sure you can follow us on our social media channels too, whichever one you use. I'm sure that we'll be there. So we're going to get going with some questions, and we're going to have all the panel members join us to see if we can do some myth busting. Let me check the time. We've got about 10 to 15 minutes. So the challenge to my fabulous panel is to give us some quick fire answers. And I'm looking, you can't tell, Sophie, but I'm looking at you because lots of these are coming your way. So buckle in. There's lots of really curious, really fantastic questions that have been coming in. Right. Super short and sharp, and if anybody needs any other information, it's always worth saying that try not to share too much of your personal health information or ask very, very specific questions about your individual health situation. That being said, now's a good moment to remind you all that if there is something that we either don't get to or you don't feel like we've covered or is very, very unique to you, please contact our nurse specialist. You may well get Sophie anyway, who'll be able to answer any of your questions. So I'm going to look over here. I'm looking at two screens. If I look away, I'm just looking at some questions. Sophie, I'm going to start with you and fire some quick ones at you. Does that sound okay?
Yeah, that's good.
Exercise is obviously good. Yes, it is. But should we avoid sex if we have prostate cancer?
No, makes no difference at all. Have sex. It's good.
Great answer. Have sex if you can and you've got the will, then please go ahead and do that. Is a very low carb or keto diet effective in slowing progression of prostate cancer? Great question.
Yeah, absolutely. No, it makes no difference. Like we spoke about diet, it's just having a healthy, balanced diet. Cutting out big food groups isn't going to make no difference. But obviously, if you enjoy a keto diet or whatever, then your choice. But it makes no difference.
Yeah, and we had a similar question about allium vegetables and simple carbs, but I think you've just covered that in terms of there's no evidence to suggest that there's
no research. And research, often you might read something that says it's good, but then you will, if you look hard enough, you'll read something that kind of contradicts it. And there's an evidence looking at kind of food is very difficult to really get good robust research on food. There's too many different things that play a part in it. So yeah, it's really difficult to say.
Thank you. And the next one is a really good question. I've heard this a lot in the cancer world, and it's such an understandable concern. So Sophie, is it likely that if you've had prostate cancer, would the biopsy actually spread the cancer?
We get this question a lot, and people are really worried about having those biopsies when they've already got prostate cancer, or if they're worried about having prostate cancer. No, there's been a bit of research done on this, looking at that, and no, that it's a tiny risk, but not a big enough risk to warrant not having a biopsy. So the prostate cancer doesn't grow or spread that way, so it's not a risk.
Great, thank you very much. Next question I've had from my brother directly to me. He's a 53-year-old avid cyclist. Are there any correlations with prostate issues with frequent bike riding with a narrow, hard bike seat?
Again, research has been done into this, and there's been contradictory evidence. So no, there is no hard evidence to say that there's a correlation. So no.
Sophie, have a breather. I'm going to come to Steve, Patrick and Luke. So we've had a question that's been sent in asking if you've joined a support group and did you find that helpful? So I'll start with Steve. Steve, have you been involved with support groups?
No, I didn't go to any support group. What I did find very useful during my diagnosis was Maggie's Centre. Talking to somebody in Maggie's Centre, and again, to be truthful, I would not have gone if it wouldn't have been for my wife saying we need to go and talk to somebody else other than me and you keep talking about this. And I find it, Maggie's Centre in Nottingham, the two ladies there was absolutely incredible on me, and they, invited me to a couple of meetings, which I did go there, but not was I call a support group. But it's fantastic help out there, and these people are out there to help you, and really are. So you should never sit in fear of not talking to somebody, going into Maggie's or going into, I spoke to prostate cancer. I spoke to Macmillan on the telephone as well when I've really been really down.
Yeah,
so.
two fantastic organisations. I think most people understand Macmillan as being, the biggest cancer charity, but for those that don't know, Maggie's is another cancer charity, and they're based across the UK. I think they've got almost 20 centres now. Ordinarily in the big cancer centres, I've been to the one at Nottingham, they're always beautiful buildings designed by incredible architects, and they operate around what's essentially at the kitchen table. Their ethos is around getting together around the kitchen table. You walk into a Maggie's centre and they are just fantastic. So thank you that's a really great tip, Steve. Thanks. Luke or Patrick, support groups?
For me, I didn't join a support group. I didn't, in fact, go online to see what was being said in forums, but I didn't actually participate. I don't know why. My real support came from my case nurse. Her name was Jane, and therefore I understand why Patrick was earlier really giving praise to our case nurse here. But I had a really good support team around me, from friends to colleagues, and therefore I didn't see the need to join one.
And finally, Mr. Williams, support groups, fan, not fan?
Well, I mean, I'm not really attached to a support group. I do support the group that Jeff Thompson runs, which is Cancer Don't Let It Win, and I have given talks there, and I kind of visited and dip in and out of his, online talks. But really and truly, I'm not really part of a support group. I have 4 sons, and 3 of them have given me grandsons. I have only boys. I have 12 grandsons. Who needs a support group when you've got that? Because they keep me on my toes every minute of the day. Plus, I go out and I give talks. And the one thing that I can do, and I can say this, for me, every time that I go and I give a talk on awareness for prostate cancer and I share my story, that strengthens and builds me up so much that I come away feeling like a giant. So, I mean, I really don't have bad days as such, because it just isn't. It isn't there for me. I do think that support groups are necessary, don't get me wrong, because a lot of men do that, but I am not one of those men. I am more of the person who goes out there and shares my experiences, and I get both sides. I see people being strengthened, and I get strengthened because of that.
Thank you. That's a really lovely answer. Thank you all of you for sharing that take on support groups. It's probably a really good moment for you to mention our partnership that we have with Tackle Prostate Cancer, who we jointly run. We support Tackle to lead a whole UK-wide network of support groups. They are super. So head to the Tackle website if you would like to join a support group. Sophie, I'm going to come back to you if that's okay. Can radiotherapy affect somebody's weight?
Not radiotherapy specifically, if they're having it to the prostate, but most commonly radiotherapy is given with hormone therapy. And so therefore it could be the hormone therapy that's affecting somebody's weight, because with removing the testosterone, often men can put weight on. So it might be that they're on hormone therapy. Obviously you need to know more, but if that person wanted to contact us, then obviously we could talk it in a bit more detail.
Thank you. Thanks very much. And then we've had one which might be tricky because it's probably a bit of a, it depends, but I'm going to ask it because it's really important. As part of the post-op recovery, so presumably someone's had some surgery, how long does it take for erections to start to return?
Yeah, it's a tricky one. And obviously we have a sexual support service that we can speak to men about their erectile dysfunction, and which it might be helpful to give us a call on that, which you'll find on our Specialist Nurses Get Support page on the website, because it depends on a lot of things after surgery. It depends on how your erections were prior to surgery, whether or not you had nerve sparing surgery, whether there was 1 nerve or 2 nerves. Can depend on how good the surgeon was as well, and how many operations the surgeon's done. It can take anything from a few months up to a couple of years. It also depends on if you're having any help to begin with. You know, if you're doing penile rehabilitation, so taking pills and vacuum pumps to try and help aid recovery. So there's a lot to really discuss, and you know, would welcome your call to be able to discuss that with you.
So that's the sexual support service that you'd encourage men to get in touch with and
Yeah,
ask for.
absolutely.
Great, thank you. Steve, you've got a fan in the audience. I'm just going to read this out to you. Thank you very much, Steve. I've been diagnosed with prostate cancer and I'm fed up with people telling me that it's okay because it's the best cancer to get and there's loads they can do these days. And he's put, surely no cancer is good cancer. Is that something you've heard?
Yes, I have. Yeah, one of the people say to you, well, it's one of the better ones you can have. Trust me, it's not one of the better ones you can have. It's the same, it's a cancer that, you know, has to be eradicated from your body. So yeah, there's no what's it in that.
No.
I wouldn't take any from that.
Yeah, very much part of the myth busting as well, that, you know, men die with it rather than from it. So it's really, really important message. We've had a really interesting one, Sophie, that's probably a little bit around active surveillance. So firstly, the question is, if you have a cancer in your prostate, surely it's best just to cut it out. So maybe just give us a tiny insight as to what active surveillance is and how that might play in with that question.
Yeah, so there are some prostate cancers that actually are cancers that men can live with and that might never die from. Prostate cancer is really can be two different diseases. It can be a disease where, as I say, men can live with it, and it may never progress. It might be a really, really slow growing prostate cancer that just sits there and doesn't grow enough in a man's lifetime. Or it can be, unfortunately, like Steve's, like Patrick's, and sorry, Luke, I didn't quite get where your stage of your disease was, but and it can be something that does grow, and unfortunately men can die with. So two very different types of disease. Now, this disease that we have, where it can be a Gleason 6 or even a Gleason 7, where actually we're catching it really early, and the more that we're telling men about their risk and telling men that PSA testing is really good, if considering PSA testing, the more actually we may well be catching men's prostate cancer really early. That actually, active surveillance is a really good choice, because this might never be either one, it might never be something that does grow to cause you any harm, or two, it might be something that you do want to that actually at the moment isn't something that's going to do anything. And active surveillance is that monitoring to have curative treatment when curative treatment is the right time to have curative treatment. So yes, we might want to cut out the prostate cancer or do radiotherapy, some form of curative treatment, but it's about doing it at the right time. Because it comes with so many side effects, it's about only wanting really to get those side effects when it's the right time. So there's lots of nuance with active surveillance, and but if you're offered it, it means that it's safe and it is a form of treatment. So you've got to it's understanding that, and it's anxiety provoking, and but it gets easier as the longer you're kind of on active surveillance.
Very tricky concept.
It is. We have support groups to be able to help men, so that's another thing that you can find on the website. So sometimes that can be really helpful, talking to men who've been on active surveillance for 10 years. So that can be a really helpful tool.
I'm told
Chiara,
yeah, go ahead,
sorry,
Patrick. Go ahead.
Can I just sort of answer what Sophie has, because she said she didn't know where the stage of my situation was. I was Gleason 10, right? Inoperable. And terminal, but I'm here. So, and I'm on hormone treatment, and I had chemotherapy.
Thank you. Thanks for clarifying that, Patrick. Yeah, one of my colleagues is telling me that there's lots of love in the chat for support groups. So just a reminder, it's Tackle Prostate Cancer, and they run support groups from their own organisation, but with all of our support. They really are a fantastic organisation. So please do that. Folks, we have got 2 or 3 minutes left of Q&A, believe it or not. I'm going to try and ask, let's have a little look. We've been asked what's an enlarged prostate, so I'm going to just be brave and say, please go to our website and take a look at our information about enlarged prostates. We've also been asked about how best to manage weight gain after surgery. Sophie, is there any quick tips, or is that information on the website as well around managing weight on hormone therapy?
You said after surgery, Chiara.
Sorry, yeah, after surgery.
After surgery, yeah. I mean, it's not, it's not a necessarily a side effect after surgery. It might just be that you're, unless you've been on hormone therapy as well, so it might just be where your activity's gone down a bit. So it might just be, looking on the NHS website, and they've got lots of information about how to help with weight gain. So it might just be something like that.
Great. And then I think probably the last one before we tackle the elephant in the room, we've been asked a lot about screening and PSA testing. And I've managed just to click away from it now. 1 second, Sophie. We've covered that one about weight, active surveillance, dairy products. It's just gone out of my line of sight. So let's just wrap up with the big question. We've been asked about surely how often to get checked. Surely it would be better if every man had a PSA every year. Look, just the ultimate aim for us as an organisation, we are Prostate Cancer UK, and wouldn't it be a great day if none of us needed to work for Prostate Cancer UK. So our ultimate aim is to find a test that is accurate enough and smart enough and quick enough and safe enough for us to be able to use in a screening program. The honest truth is we don't yet have enough of the evidence that the National Screening Committee need for us to be able to start doing that screening program for all men. We're close, but we're not quite there. And that's a really difficult thing for me to say, because we all at Prostate Cancer UK want to say, now's the time, come on, now's the time. We understand it's incredibly emotive. Couldn't we just have a PSA test every year? But unfortunately, we still know that there isn't quite the information and the evidence that we need that tells us categorically that we're not doing more harm to more men. And that doesn't take away from the lives that we would save by doing that. But we can't get away from the fact that the National Screening Committee take the other side of that incredibly seriously when it comes to planning a national screening programme. But please take my word that we are laser focused and spending an enormous amount of money on research looking at early diagnosis and what the National Screening Committee need to give them enough evidence, the right evidence, to get a screening programme for all men. Having said that, we have as an organisation submitted some evidence and some proposals to get 2 targeted screening programmes this year. One for Black men over 45 and one for men with a history of prostate cancer in their families. Because as an organisation, we strongly believe that we do have the right amount of evidence, whether that's clinical and academic evidence, as well as what we call real world evidence, what we can see happening on the ground in the NHS, that gives us the information that we need, that we really, really think the evidence is compelling. We've submitted that to the National Screening Committee, and we will hopefully find out in the next, hopefully 8 to 10 months as to whether they have been successful submissions. But as you can imagine, these are really long processes. But again, to wrap up, this really is our promise to you that we will not take our eye off the ball. We know that this is the really big thing that everybody wants us to do and get over the line, but so do we. And we promise that the minute that we have enough to be able to do that, that will absolutely always be our priority. So let's take a look. We are now, as you can imagine, approaching the end of our webinar. So we hope, as I now do, we all feel a bit more empowered with the knowledge and equipped to go out there and dispel some of these myths around prostate cancer. And please remember, it is crucial to speak to your family, your friends, your colleagues, spread the word unashamedly with no embarrassment about what prostate cancer is, what to look out for, what not to look out for, encourage that really strong risk message. So before I hand back to Marvyn, who's going to close out today's lovely evening session, we're going to ask you 2 more really quick questions on some polls. So firstly, why did you choose to attend this webinar? I'm going to just give you a few seconds to answer that. It looks like you can answer a few. I think select all that apply. Yes, you can. Thank you. This is great. Thank you. Keep them coming. Half of you have now completed the polls. Let's see if we can get it up to 100%. Give it a few more seconds. Okay, that's starting to slow down. So I think we can ask our second question. How would you rate today's webinar? Oh, it's flying up this time. 80%. Well done. Keep going. Okay, I think we can probably end the poll there. So I'm just going to say a huge thank you. Thank you so much for joining us this evening. It really is a privilege to be able to spend time with men like Luke and Patrick and Steve that really remind us why we do what we do. So thank you all for sharing your stories. Thank you everyone for coming, and I'm going to hand over to my co-host Marvyn, who's going to close out today's session. Over to you.
I just wanted to say thank you to everyone for joining us today. Also, in addition, it's been an absolutely enlightening session. I feel like I've come away learning more, even after so many weeks and months of ingesting so much information. I love hearing the real stories of real people who are doing the work on the ground. And I can't explain how valuable that is for people like myself who are entering that phase in their life, but also clearly everybody else that's been on this call. Before we conclude, I just wanted to leave you with a really strong call to action. We want you to take a look at the film that we have done and share it with our risk checker, with the men in your lives. And there's a link in the chat we'll follow up with in an email to everybody after this call also, and everything you need is in there. So there is this amazing film. The link is in the chat. Please make sure you check it out. Make sure you share the risk checker with all the men in your lives and really start the conversation. And I call it enrollment, when you invite people into something that's really important to you or something that you feel like is really important to them, enroll them in. And thank you so much for being here today. And I look forward to seeing you on the next one.
Thank you.